your hobbies, what you like to do. Don't give up having children. I know some people say, no, I'll not have children because I'm in pain, I have chronic pain.
Hi everyone, welcome back to this week's episode on Take a Pain Check. I'm excited to have Dr. Furlan joining me today. Hi Dr. Furlan, can you give me a brief introduction about yourself? Tell me a little bit about your education, your career, and what you've been up to recently.
Yeah, thank you. Thank you, Natasha, for inviting me to be here. Your podcast and your program is so important. I'm really honored to be here today, talk to your audience. Yeah, so I am a physician and I work in downtown Toronto in the TAPME clinics, Toronto Academic Pain Medicine Institute. I work at Toronto Rehabilitation Institute, which is one of the hospitals of UHN. And I did my medical training in Brazil and also my specialization in physiatry, physical medicine, rehabilitation in Brazil. And when I immigrated to Canada 27 years ago, I did my PhD at the University of Toronto and then became a assistant professor of medicine. And now I am a full professor of medicine in the Department of Medicine of the University of Toronto. And what I'm up to, I see patients in the pain clinic. I am a clinician in a multidisciplinary pain program. I'm also a scientist. I'm a senior scientist at Toronto Rehab, which means I have to research methods to treat chronic pain. That's my area that I specialize. I only see people with chronic pain. And then I find the best treatments for them. And I also have some programs to educate healthcare professionals like doctors, nurses, physiotherapists, pharmacists. Most of what I do is teaching healthcare professionals about the science of pain, chronic pain, and how to best treat chronic pain.
Thank you for sharing that with me. So I want to go a little bit back and talk about when did you know you wanted to study medicine and what that pathway was like for you?
Yeah, I know. Some people have, their path very clear in their mind and they know they want to do this. I think I was one of those, which is, kind of rare. But my family, they tell me that since I was 2 or 3, maybe 4 years of age, I said I wanted to become a doctor and I wanted to become a pediatrician because I love to treat children, but I also wanted to become a teacher. So those two things, and I had to choose. But now I am both. I am a physician and a teacher, so I kind of fulfilled my two desires, my two dreams. And then I decided to become a pain doctor. I had no idea that when I was in medical school, I had no idea that I could become a pain doctor. I did not know that this existed, but then I came across physiatry, which is the physical medicine rehabilitation. We do see a lot of people with disabilities. That's what physiatry does, is the physician of a person like a spinal cord injury, paraplegics, tetraplegics, or people who have amputations or stroke, and they need to do rehabilitation to regain function. A lot of these people have pain and chronic pain. So then I specialized to become a specialist in chronic pain.
Do you have any lived experience of chronic pain, or do you know anyone that lives with chronic pain that kind of also led you to this journey?
Well, who doesn't have an experience with pain? Yeah, I don't have chronic pain, but I had a lot of acute episodes of pain in my life. So when I was a teenager, I had terrible monthly menstrual cramps, and they were very debilitating. And that was also what led me to, in medical school, try to help people who had pain, because I found I had to miss important events and tests and exams in school. And I found how come that, pain, we still don't have a cure for pain. And then when I was in medical school, I tried to help people with pain. And it was actually one person that changed my career that made me choose pain medicine. I remember her very well. I was in the internship before I had to choose what kind of specialty to choose, and I did not know what I wanted to be. And then we admitted this lady, I can't remember, she was probably 50 or 60 years of age. And we admitted her from the emergency to the internal medicine ward because we needed to investigate her. She had pain all over her body. And she came to emergency because she had no idea where to go. And when we admitted her, we did all tests. We turned her inside out and we did everything and everything came back normal. And my attending told me, well, why don't you call a specialist in physiatry? And I said, physio what? So here comes a physiatrist who became my mentor and my friend. And interesting, he came with needles to do acupuncture needles. And now, so he examined her and then he put needles on her. She was in bed. She couldn't even move. If you touch her, she was screaming of pain and nobody knew what she had. So he put acupuncture needles on her and was talking to me. 30 minutes later, he removed the needles and the patient was walking in the corridors, pain-free, and we discharged her the next day. But then I asked him, I said, what did you do? And that's what opened my mind to the fascinating world of pain, because he told me, well, she has fibromyalgia. And what I did was I just stimulated her brain stem, which is, here's the brain stem, here's the brain, it's like the trunk of the tree. And in the brain stem, we have an inner pharmacy. I just opened the doors of her inner pharmacy and she produced her own opioids, endorphins, dopamine, serotonin, like all those neurotransmitters that we need. And then he told me, but those pharmacos that she released, they will last up to 7 days, and then she'll be back to what she was before. And that was for me fascinating. I said, how come that we don't know about this inner pharmacy? We need to study more. And so she really changed my career path.
Wow, and I think also just learning from other people's lived experiences can also shape the way you want to do things. And even though it may not be yours, I think other people in the community and society definitely have an impact. And I'm wondering, because you did your medical school in Brazil and then you came to Canada, did you find any differences in the healthcare system from Brazil and Canada, and how did you adapt?
Yeah, Natasha. For me, yeah, many differences. Not so much in how the patients present, because fibromyalgia is the same in Brazil and is the same here. But for me, Natasha, the major difference that I found, and I was shocked, is the amount of opioids that was prescribed to patients here in Canada. That for me was unheard. Even nowadays in Brazil, when I talk to my colleagues who work there and I tell them the amount of opioids that I see in my clinic, they get horrified. They say, we don't see this here in Brazil. And for me, nowadays I see less than I came to Canada 30 years ago. No, 27 years ago. I graduated from medical school 32 years ago, but I came here 27 years ago. We were in the epidemic of opioids in Canada and in North America, actually came from the United States to Canada. And I started there and then came to Canada a few years later. Like everybody who had pain were prescribed opioids, and that was the norm. And not only opioids, but high doses of opioids, because your body creates tolerance and then the effects kind of fade and you need to increase the dose to have the same effect. That was what shocked me mostly.
It's always interesting to kind of hear perspectives of across the world. And I think a lot of the times, although the healthcare system is similar from what it sounds like, in different countries, there is different access to care and things like that. And so it's important to always acknowledge that. And I'm glad that, the work that you've been doing has been very significant. Have you been back to Brazil and kind of been able to reach that audience still,
Yeah.
or the population, in terms of helping them with pain management and chronic pain?
Yeah, it's interesting because I did my PhD here and I'm working here. So my colleagues are always inviting me to be like a keynote speaker, to give lectures at the conferences. So once in a while I go back. Almost every year I give a lecture there, either via video conference or they invite me to go, which is nice. And so I keep in contact with them. I publish some papers, scientific papers with people in Brazil. We just published a paper looking at the opioid utilization in Brazil, because now they have a large database that can monitor the prescriptions of opioids. So even though it's not exactly like Canada, no way big, but it is increasing slowly. And yes, I keep in touch with them, and they're having the same issues that we have. Population is getting older, and then they are seeing more people with generalized pain, more people with arthritis, more people with low back pain, which is one of the major causes of disability. Actually, it's the number one cause of why people stop working in the world. Is the number one cause of disabilities. It's back pain.
Would you be able to talk a little bit about the role of opioids in pain and chronic pain? I feel like we've been kind of talking about it but for people that may just be hearing this for the first time and might be like, what is the role and why are people using this? Would you be able to share some information?
Yeah, I love talking about this because it's a topic that is poorly understood, not only by people with pain, but also by healthcare professionals. What happens is opioid is the strongest analgesic that we know. It's godsend. It's amazing. It's found in a plant. The poppy plant contains morphine and codeine. And we have many others that are made in laboratory. They are semi-synthetic or synthetic opioids. So these medications, they are potent analgesic. We have receptors in our body for opioids. But the thing is, we also produce our own opioids. Like as I mentioned before, the pharmacy in our brainstem is able to produce endorphins, dynorphins, enkephalins. These are our endogenous opioids. We produce them. And endorphin is actually much more potent than morphine. What happens is, if a person is in acute pain, which is usually nociceptive or neuropathic pain, I can explain to you later what is these names, because I know they're kind of complicated names. But nociceptive pain is the pain that we all feel if you have like a broken bone, a fracture, if you have an inflamed tooth, or if you have an appendicitis. That is what we call nociceptive pain. It means that there's something broken, damage, or injury, or disease, and that the brain is detecting a dangerous signal. For this kind of pain, opioids are excellent. They can block those receptors for pain and make the pain go away. Not all chronic pains are this kind of pain. Like if a person has a fracture and it heals, they don't have pain for the rest of their life. So when pain transforms into chronic pain, that's the problem. Because chronic pain is a disease that is different from acute pain. It doesn't mean that the injury continues injured there all the time. The body heals. Even if the person had an inflammation. I know a lot of people who watch your podcasts and your videos, they have inflammatory diseases. And they know if it's an acute inflammation, they have an acute inflamed joint, they can see the redness, the swollen, and it's painful. That's nociceptive pain. Now, after that inflammation is treated, and if the pain continues, it's not nociceptive anymore. The pain transformed into something else. Could be neuropathic or could be nociplastic. The majority of chronic pain is nociplastic. Neuropathic is if there is a nerve injury somewhere there. But nociplastic pain is if the alarm system of the body is malfunctioning. So that signal, that pain signal continues turned on. It's almost like a false alarm because there is no more, I compare this with an alarm system of a house. The alarm system of a house can make noise if there's a fire in the kitchen, that is equivalent to nociceptive pain. Or if there's a short circuit somewhere, you open a cupboard and the alarm goes off, that's neuropathic because it's a problem with the wires. Or the alarm system itself is malfunction, that's nociplastic pain. And the treatments are different. Opioids work well for nociceptive pain, which is equivalent to call the fire truck, the ambulance, to your house if there's a fire. They will come, they will put up the fire, and the alarm will go off. But if there's a short circuit in the house, or if the alarm is deregulated, you can call the fire truck. They will come, they'll say there's no fire in the house. What do you do? So for those kinds of pain, especially nociplastic pain, opioids can make the pain worse. So that's why when we say opioids don't work for chronic pain, it's because the majority of people who have chronic pain have nociplastic pain, not a nociceptive and a neuropathic pain. I hope that explain a little bit to your audience why we are more reluctant to be prescribing opioids to chronic pain. First, because it may not be the right treatment for that pain. And second is it can make it worse. And third, once you start opioids, it's really hard to stop.
So what would you suggest as alternative pain management strategies that you've seen patients use aside from opioids?
Yes, absolutely. Again, and they change, the alternative treatments change if the pain is nociceptive, neuropathic, or nociplastic. Again, think about this. One is treated with a fire truck. The fireman comes to your house, put up the fire, and the alarm goes off. The other one, you call the electrician. They fix the short circuit, and the alarm calms down and stops making noise. The third one, you call the alarm company. They regulate the buttons, the volume, and the alarm calms down. Okay, so the treatments for these three types of pain are completely different. And some people have mixed pain. The problem is some people have all two out of three or all three types of pain. So for nociceptive pain, which is that pain from inflammation, from an injury, an acute or surgery. Surgery is an acute nociceptive pain. So anesthetics are really good. That's why we give anesthesia for people who have surgery. Opioids, anti-inflammatories, acetaminophen, known as Tylenol, cold ice, application of ice. So if a person has a fracture, you put ice, you kind of block the pain sensations. You can apply some local anesthetics. So those are the treatments that we usually do for nociceptive pain. But again, the body heals, and then they will not need to take this medication forever. If they have neuropathic pain, which is that pain from the nerve injury. Some people with rheumatoid arthritis, they have injuries to the nerves because of the inflammation that they have around the joints, damage the nerves that go around the wrists, the shoulders, the neck. So they may develop a neuropathic pain. And for those kind of pains, we use medications that kind of block the nerves. They can be anticonvulsants, anti-epileptic medications. So you probably have heard of gabapentin or pregabalin. And we also give antidepressant medications because they kind of increase serotonin in the pain system and help to fight the pain signals from neuropathic pain. Okay. Now for nociplastic pain, again, there's no fire in the kitchen. There's no short circuit. We're not going to give those medications for them. Medications is usually not indicated for nociplastic pain because you need to regulate the volume of pain, teach the pain system that what they are feeling is actually not damaging. It's just a misfiring of information. Although, let me make it clear here, Natasha. I'm not saying that that pain is imaginary, they're faking, they are not feeling it. Nociplastic pain is very real, and it's probably the worst type of pain. Okay, so that's very real. An example of nociplastic pain is fibromyalgia. Another example of nociplastic pain, you may have heard about that, complex regional pain syndrome, CRPS. Tension headaches is a type of nociplastic pain. Irritable bowel syndrome, some majority of chronic back pain, temporomandibular disorders, when there's nothing, there's no dislocation of the jaw or inflammation of the joint, but it's more like that tension in the muscles here, that is also nociplastic. So for these ones, they need to do what we call mind-body interventions, connect the mind, the body, retrain the pain system. And for those ones, they can find a good physiotherapist, occupational therapist, psychologist, that they are trained in mind-body interventions. Pay attention to sleep, nutrition, what they eat is extremely important. How they sleep, the amount they need to have quality sleep, because it's during the sleep that they are going to create, fabricate those endogenous pharmaceuticals that we need. So there are a lot of lifestyle modifications. Smoking is a no-no. And alcohol, try to limit at the maximum that they can, if possible, stop.
Thank you for sharing that information. I think a lot of patients like me and other patients may not know all the different kind of options out there. And what it sounds like is it's also personalized and personal to each person. Like, not every single method is going to work on everyone. And that's why you have kind of these experts working with you to do that. And so I was wondering, when it comes to, we talked a little bit about, the healthcare differences between Brazil and Canada and the different ways people can manage pain, and it depends on the type of pain they have, things like that. Do you work with young adults, youth, adults? Like, what does your practice look like?
Yeah, everyone. I don't treat children because they go to the hospital for sick children, but even teenagers, when they are ready to be discharged from a pediatrician or pediatrics hospital, they can come to my clinic. Unfortunately, because I work in a pain clinic, unfortunately, I don't have the capacity to keep seeing them forever and ever. I wish I could keep them in my clinic, but because I am kind of a consultant, I receive referrals from doctors in the community, family doctors, or the specialists, pediatricians. I see the patients, we do this assessment, we give them the diagnosis, what is the cause of their pain, and then I give them a plan for treatment. I see them for a few follow-ups, maybe 2, 3, 4, and then after that, they need to continue that plan with their primary care provider. But I understand a lot of people in Ontario don't have even a family doctor. I understand. But they, sometimes they can keep following with a physiotherapist, a social worker, a psychologist, chiropractor. So they're all part of the primary care team. Yeah, so what we recommend, how my practice looks like. I get these referrals, they have to come, and then we do a very intense assessment. Natasha, the assessment is so tiring and so exhausting that we now have to divide into 2 days. They come 2 days. The first they come to do a lot of the questionnaires and physical assessments, and then the second time they come to see me or my team. Then we look at everything they have done. We look at the questionnaires they completed, the physical assessments. I examine them, I talk to them, and I explain. And I see people, as I said, from 15 years of age to 100, men and women from all kinds of backgrounds, some people don't speak a good English, they don't have a good understanding of English, they come with an interpreter. And I think what I see most in my clinic is a lack of understanding, of knowledge. The patients, when they come to me, nobody ever explained to them what they have, why they're hurting, why they are receiving the treatments they are. And it's so sad because I usually see people who had tried everything for so many years, 20 years, and they still are in pain. They are now fatigued, exhausted, frustrated, angry. And then I have to pick up the pieces and see, what are your goals? I work a lot with patients' goals. I say, if eliminating the pain is not possible, I will try. I will make sure I will try to eliminate, reduce your pain. But if it is not possible, what can you do with your life? Your life continues. You cannot stop your life. And it's eyes opening for a lot of people, because you have no idea how many people stop living because they have chronic pain. They literally stop living. And for me, that's the saddest part, because I have so many examples of people who have chronic pain, serious diseases, and they are living a very fulfilling life, a life that they enjoy, that they can contribute to society, that they are happy. It is possible. I try to convince my patients that it is possible.
There's a lot of patients in the rheumatic disease community that are primarily diagnosed with a rheumatic disease, and then after a while, I've known people that have been told that actually you just have fibromyalgia or you just have chronic pain and you don't actually have arthritis, and they find it so hard to then manage their life with chronic pain. They just don't know what to do, and they get very confused with the misdiagnosis of, I had arthritis and now I don't have arthritis because I actually just have some sort of pain. And I've been talking to so many of these. I've like seen firsthand some of my team members experience that as well. And I see how challenging it is. Like people that have fibromyalgia and chronic pain, they don't have direct like medication they can take like someone who has arthritis, who's on infusions or biologic medications and all of that. And so I can totally see how people may be discouraged because of this, because, they may seem like there's no hope or there's nothing I can do. I have to just follow through with this plan. But like you said, some of them might not have a primary care physician or might not have the specialist available. And so I'm wondering, with the work that you're doing, because I know you're heavily involved in a lot of advocacy initiatives, community awareness, all of that, and research, what is the research that's happening lately? And do you have anything that you can kind of say to this audience who may feel like there's no hope for them?
Yeah, I totally understand. And there is a lot of new understanding. It is amazing what we know now about pain itself that I did not know 32 years ago when I graduated from medical school. Like I heard about fibromyalgia in medical school because that was the patient with fibromyalgia that brought me to pain medicine. But at that time, like fibromyalgia was well known, we knew about it, but then we did not know exactly. Like my mentor told me with acupuncture, he opened the pharmacy, she released endorphins, but then 7 days later she would be the same. So how do you treat? And we had no idea at that time what was chronic pain in fibromyalgia. Now, in the last, I would say 15, 20 years, with functional MRI, we can see the function of the brain. And the amount of studies and the amount of research and the amount of science, it's exploding. Everybody now who does any research with pain patients, acute or chronic, is now doing functional MRI because you see what's happening in the brain. We are not using functional MRI to diagnose people individually. That is still not a good idea for a lot of reasons. One of them is that you can have false positives and false negatives. And we don't want to, it's not because if we do a functional MRI in one person's brain and we don't see anything, that person may be labeled as, oh, I can't see anything in your brain, so you're not in pain. So that can happen. Or a person may not be in pain at that moment, but by thinking and remembering pain, they can light up all of those areas, okay? So it's not good to use clinically, but when you do functional MRI in 10, 20, 30 people, and then the computer combines everything, you see patterns. And this is amazing because now, I think that's where the treatments and cure for chronic pain and pain in general will come. Because we see now in the brain areas that are able to inhibit other areas. We are able to see how the limbic system in the brain, it's the part of the emotions, feelings, fears. There is a center there called, in the part of the limbic system, one of the parts is called amygdala. And in people who have like an acute episode of pain, or even a chronic pain that they are frustrated, the amygdala is not only bigger, but it's lighting up all the time. Why? That's because that's the center of fear. You can light up the amygdala by putting a person in a very fearful situation. So why someone who is living with chronic pain, the amygdala is light up like a Christmas decoration? very bright, and it's bigger. So we now know that there are some relationships with emotions, how the person reacts, and that it's beautiful because it brings the cultural aspect of pain. We define pain as a biopsychosocial phenomenon, which means when a person tells me I am in pain, I am feeling pain right now, there is a biological thing going on in their body, there is a psychological thing going on in their body, and there is a social thing going in their body around them, which means that if you change the social context where the person is, the same person with the same injury may say, I don't have pain, or I have the worst pain in my life, just changing what is around them. Natasha, this is amazing. And I don't know if you heard about this, but there are reports from the physicians who work in war camps. And they write papers and they describe what they see in those war zones. And there is a doctor, he was a doctor in a war zone, I think during the Second World War. And he said 1/3 of the soldiers who had a very severe wound, they come to me and they say they're not in pain. Because he had to ask them, he had to administer morphine for them at the medic side, right? And 1/3 could be an amputation, could be a gunshot, could be a cut, it could be a burn. 1/3 did not have pain. How come? Now, if you get the same person and bring that man or woman who was in the war, bring them to their house and burn them, say, I'm going to burn you the same amount of burn, they're going to feel pain. So it's the context, so pain is biopsychosocial. And we have an amazing ability to suppress pain and to create pain. I tell my patients that the brain is so powerful that it can create pain and stop pain. How can the brain create pain by itself? Imagine someone who had an amputation. Person doesn't have the leg anymore. I see a lot of people who are amputated. I do physiatry, I do rehabilitation of people with amputations. I don't do that much anymore, but I did a lot. They have feelings in the foot. They feel the foot, and some of them feel pain in the foot that doesn't exist anymore. So I think that's where the future of pain is coming, is from understanding the influence and the power of the brain stem, the spinal cord, the nerves, what we can do with those areas.
Thanks for sharing that, Dr. Furlan. Yeah, I totally agree with you. And I think a lot of people don't really know the connection between the brain and pain, especially the patient population. I think even for me, sometimes just going to the doctor and filling out, like, what is your pain scale? It's so hard for me to explain what my pain scale is. And then also, like, I think it's also very subjective. Like, my 10 might not be your 10, and my 1 might not be your 1. And so there's a lot of work still to do with that. And I'm sure that a lot of researchers are working on that as well to figure out, what are ways people can kind of describe their pain, communicate their pain, things like that.
Yeah, yeah, absolutely. In this field there are a lot of researchers around the world that are trying to improve that. I go to all pain conferences that I can come across and I can go. I love to go to the International Association for the Study of Pain, IASP conference, because that brings researchers from all over the world. Last August, it was in the Netherlands, in Amsterdam, and there were more than 4,000 people from all over the world. Most of them were researchers and clinicians, and also some patients with lived experience who participated, and a lot of students, graduate students who are studying pain. And it's fascinating because you see people from different areas of the world who are trying to look at answering questions that sometimes you did not even know that you had that question. And And this topic of measuring pain is usually a very hot topic during those pain conferences. People are trying to identify more objective signs. How can we objectively determine if a person is in pain, especially because there are babies, newborns that they can't talk. So they do research looking at the facial expressions of babies to see if they're in pain or not. There are people with dementia. There is a group that are only looking at people with dementia because they don't talk. And how do you know if they are in pain or not? So there are also other measures that you can look. There are people with mental disabilities that can't communicate well, children with autism. There are so many important things that we need to develop methods to identify not only the pain intensity, but also where is the pain, and also how much is this suffering. For me, the pain intensity is different from suffering from that pain. I wish we had a better measure for distinguishing both, because a person, I've seen people who have a very intense pain, but they're not suffering that much. And I see people who have a very low intensity pain and their suffering is huge. So when they complete those numerical scales, I think for them it's so difficult to distinguish what is the pain intensity and what is my suffering. When I say suffering, the suffering from pain is very complex because it involves all those thoughts that go into their mind. For example, let me give you an example of a person that is having a very intense pain, but they're not suffering that much. You probably heard about labor pain, and labor pain is considered very intense pain. And you can see some women delivering a baby in 10 out of 10 intense pain, but they're not suffering. Like it's one of the joyous moments of their life. They're giving birth to their baby, to their child, they're happy. You don't see the same intense suffering that if someone has let's say a minor injury in their hand, and but they have an injury that would be, let's say, a 1 or 2, because it's not so severe. It's not like compared to a labor pain. But if that injury, let's say in their hand, is going on for 20 years, it's constant. They already tried everything under the sun. They already went to 20 doctors. They did 15 MRIs, CT scans, X-rays, everything. Nobody knows what they have, and it's still hurting every day. Even though it's a minor injury, you say it's not compared to labor pain, it's a minor thing, but they may rate that thing as a 10, because you see the amount of suffering that they are carrying because of that pain is a 20-year history. So when they give me the numbers, and I use those numbers in my pain clinic, they give me those numbers. I try to understand, is this the amount of injury? Because you can have a big injury in your body and not have any pain. A lot of people have cancers. They have ovarian cancer, no pain, or they have myocardial infarct, silent, no pain. So they may have something really serious in their body and don't feel any pain. Or they have the opposite, something that is not serious. Like fibromyalgia, it's not a serious disease that's going to... Fibromyalgia doesn't cause any lesion in the body, doesn't cause any damage to the body. It's not going to kill the person. So it's not a disease that we would say is a severe disease that it's going to damage your body. It doesn't do any of those. But look at the amount of suffering. Imagine having pain all over your body all the time for many years. The suffering is immense. So the number that they give in those scales usually is not proportional to the amount of injury or damage in the body. It's more proportional to the amount of their suffering, their fears, their insecurities, their frustrations.
Thank you for sharing that. You are most known for your YouTube channel where you discuss chronic pain, and I know you were talking a lot about education and educating the community, physicians, and allied healthcare professionals, and also patients. So, can you talk a little bit about this YouTube channel, what the goals are for the channel, and why you started this channel?
Yeah, that's very simple. It's because I love teaching this to my patients. And I don't have time during my clinic because during my clinic encounter, I need to review all of those questionnaires that they completed. I need to get some details about their pain. I need to examine them. And then I have maybe 5 minutes at the end for me to tell them, this is what you have. And I have another patient to see next. And for me, that was so frustrating, Natasha, because I, I can't just tell the person, oh, you have fibromyalgia, go and be happy. And here is a plan. I'll send your family doctor and everything will be right to you. I felt that need to explain to them what is this diagnosis. If I made a diagnosis of a peripheral neuropathy or shingles or neuropathic pain or low back pain, I felt the need, I needed to explain more. So that's why I started the channel, only for my patients. And I started in 2019 with my cell phone. This was my camera. Here, this is the room that I record all of my videos, and started putting on YouTube and quiet. I didn't even tell my parents. I was afraid, didn't even tell my colleagues because I was afraid that they would see me as a YouTuber. And YouTube, people making fun and dancing and comedy. I didn't want to be seen like that. So I just put on YouTube because YouTube is accessible. And I could also put closed captions. All of my videos have closed captions now in more than 50 languages. But I said, okay, I can increase the accessibility for my patients who don't understand English very well. They can go home and they can watch me. It's almost like an extension of my consult. They can watch me explaining to them at home when they're relaxed. Maybe they have a family member to watch with them. And my patients love it because they say they go home. And I prescribe the videos because I have more than 200 on my channel. And so I number them and I say, when you go home, I want you to watch the number 59, 112, and the 156, because these are for you. And then during the pandemic, I also demonstrate a lot of exercises. Before I had my channel, if I wanted them to do exercises, I not only prescribe physiotherapy for you go and do physiotherapy, I wanted them to do specific exercises. And I was lying down on the bed in the clinic room, demonstrating the exercises. And I said, well, this is not going to work. So I started recording myself doing the exercises that I wanted my patients to show to their physiotherapist or do at home. And those are the videos that exploded, especially during the pandemic, because during the pandemic, people could not access physiotherapy. So my videos of exercises I have videos almost 10 million views now, because they really are, I think people find it helpful. And now my mom and my dad, they're the most, the ones that promote my videos in Brazil. They tell all their colleagues to watch my channel. And my colleagues in Canada now, I sometimes I see them and they say, oh, Andrea, I'm prescribing your videos to my patients now because I know they are from a reliable source and I know you're doing a good job. And so they also use my videos as a source of information for their own patients.
Amazing. Thank you for sharing that. And that's so great. I'm definitely going to link all of that down below for patients who are watching to check it out. You are doing amazing on your YouTube channel, and I really think that a lot of patients in our community would benefit from seeing some of those exercises. Me, myself, probably. I'm gonna check that out
Yeah.
right now.
I
Check it out
have
right now.
one, I have one, almost one, maybe more than 1 million views now, I can't remember. Exercises for people who have hand
Yeah.
rheumatoid arthritis. And I got those exercises from a randomized trial. Look at this. There was a randomized trial published. When I did the video, the randomized trial had been published, I think, 5 years before. And I did not know. Nobody did like some propaganda. These people from Canada and UK, they developed this amazing exercise for hand RA, published the paper, And that's it. And that's it. I said, oh my God, how do you expect patients to go and read your paper and do the exercises? So then I did the video demonstrating the exercises that they demonstrated because they were effective in the randomized trial that they did. So I find also, Natasha, that doing those videos, I can help research that has been published and archived and nobody reads to make where it needs to be, which is in the hands of the clinicians and in the hands of patients.
Yes, Dr. Furlan, it seems like you are making that information digestible so that public audiences can really understand these intricate topics that are being discussed. So that's great. You also are an author and you've been publishing books, and you have a new book that is released on April 1st. Can you tell me a little bit about what the book is about? Why did you write it? And what do you hope people take away from reading it?
So this second book is more like a workbook, like a journal. So here it is. Oops, that's the second one. And it is more for them to write. It's more like for them, I want them to think about, because my first book, that one, The 8 Steps to Conquer Chronic Pain, is very text-based. And it is more things like to read. I also have cases that I explain here. I summarize things in diagrams. I try not to be like too heavy on text. But this one is not for them to write on. It's not for them to do the exercise. So this one is 90 exercise, 90 days that I recommend them to do some things to understand what's going on in their body, to understand the connection between their mind and their body, to create lists of things that trigger that pain, to create lists for things that work for them. So this book is something that is going to be unique for each person. Like there will be no two persons in the world that will do the same thing. That's why I say you are unique, because you are unique, a unique person. What works for you may not work for another person. That's why I want you to discover what works for you. And the intention here is that they will do the work. They will need to sit and do the work and think about those important things in their life, and don't stop living. The main goal of the two books, this and this, is that I want to show to them that it is possible to have a chronic disease. It is possible to even have chronic pain, but have a fulfilling life, to conquer the chronic pain. I've seen this over and over, and I don't want them to give up their lives. For me, what makes me really sad is when they stop living.
And I wanted to end off the podcast episode with an advice segment. I mean, like, you've been kind of giving advice throughout and sharing amazing information that is so valuable to people living with pain. But I wanted to end off kind of asking you a question more so related to youth living with pain. So, what advice would you give to youth who want to get more involved in their own pain management?
Yeah, thank you so much. You're doing an amazing job, as I said before. Um, my main advice is get education about what is the pain that you have. Don't stop learning. Participate in groups of people who know about what is pain. There are many groups in Canada. If the majority of your audience is in Canada, there are many resources. The Power Over Pain portal is funded by the Ontario Ministry of Health, the government of Ontario. There are many groups there, even for children. There is a Power Over Pain portal for children. There are seminars, workshops, courses. And then there are other groups also, like the Arthritis Society, Fibromyalgia Association of Canada. There is also People in Pain Network. And those groups I highly recommend them because they are uplifting. They will give you knowledge, the education that you need. You're not alone. You're going to see other people who have done it well and they're able to live really well. So don't get discouraged. Don't think that this is the end. Don't think that you will need painkillers for the rest of your life. Maybe the painkillers, if you are on painkillers, even on opioids, try to think of them like a short-term bridge for you to be functional. Invest on your lifestyle, healthy lifestyle. This, I cannot stress enough how what you eat, your sleep, your social networks. Don't become alone. Loneliness leads to more pain. Find something that distracts you, a hobby, something that you like to do. Focus on your goals in your life. Don't give up your school, your profession, your hobbies, what you like to do. Don't give up having children. I know some people say, no, I'll not have children because I'm in pain, I have chronic pain. Don't give up. It is possible to do all of this if you find some supports. I hope you can find a good primary care provider that knows about pain. If your family doctor wants to learn more, they can come to my courses. I give free knowledge via ECHO Ontario, ECHO, to healthcare professionals all over Ontario. They can participate. I am in front of a camera like this every Thursday. They can present cases, and me and my team will discuss these cases. So we're giving free knowledge a lot. It's just that I hope you and your doctor and your nurse practitioner or whoever is treating you will have the best knowledge about your disease, because knowledge will be your friend.
Thank you so much, Dr. Furlan, for joining me on today's podcast episode. We talked about your path in education and career all the way from Brazil to Canada. You talked about, some experiences that you've had with pain and how it affected your day-to-day life. We talked about how these different experiences and patients that you've met along the journey has allowed you to create more resources and really be involved in patient care. You talked a lot about your research as well and the education that you've been providing for free to healthcare professionals and patients. And last but not least, we talked about your new book as well as your YouTube channel, which provides content for those experiencing chronic pain. So everyone, like, comment, subscribe, check out the book, which I will link down below, and Dr. Furlan's social media channels as well. And I'll see everyone in 2 weeks on Take a Pain Check. Thank you.